Hello. In this module, I am going to discuss a very important aspect for the management of pulmonary disease, that is the management of asthma. So, I am going to discuss basically the stepwise management of asthma. My presentation is largely based on the recent GINA guidelines. Asthma, I think we know very well, is a common and potentially serious chronic disease that can be controlled but not cured. Asthma causes symptoms such as wheezing, shortness of breath, chest tightness and cough that vary over time in their occurrence, frequency and intensity. And symptoms are associated with variable expiratory flow limitation, and this is because of the bronchoconstriction, the airway wall thickening because of inflammation, and the mucus which lies in the airways. Symptoms can be triggered or worsened by factors like infections, smoking, allergens, pollens, tobacco smoke, exercise and stress. A well-controlled asthma would be a person who can avoids the troublesome symptom during day and night, need little or no reliever medications, have productive physical active lives, have normal or near normal lung functions, avoid serious asthma flare-up. So that will be a well-controlled asthma. But I think before that, once you start treating a patient of asthma, it is important to understand few important aspects of the management of asthma. First is the diagnosis. Let's go once again over the diagnosis. The diagnosis is based on the history of characteristic symptom pattern, evidence of variable airflow limitations, and from bronchodilator reversibility test or other test. And sometimes you need evidence from the notes, patient's notes, who has been seen earlier by somebody or by you, preferably before starting the controller medications. It's often difficult to diagnose asthma once patient is on treatment, because patient may not have much symptoms or may have some symptoms and his lung function study may show absolutely normal spirometry. Asthma is usually characterized by airway inflammation and airway hyperresponsiveness, but these are not necessary or sufficient to make a diagnosis of asthma. It is also important to know when you are encountering a patient that whether it is asthma or may not be asthma. So when it is not asthma, when patient had isolated cough with no really or any other symptoms, chronic production of sputum, shortness of breath associated with dizziness, lightheadedness or peripheral tingling, chest pain, exercise-induced dyspnea with noisy respiration, that means he's got stridor. So these are not asthma. When you examine these patients of asthma, often they are normal, because they come to you when they are stable, they may be often normal. The most frequent finding, of course, is a wheezing and auscultation, especially on forced expiration. But one should always remember the wheezing is not only caused by asthma, it can be by respiratory infection, by COPD, upper airway dysfunction, endobronchial obstruction or inhaled foreign body. Wheezing may also be absent, like a person who get a very severe attack of asthma, wheezing may also be absent. So once you have taken a history of a patient which is suggestive of asthma, the next important thing is to document it or confirm it with the lung function studies. It is essential that all patients, when you diagnose asthma, they should undergo a spirometry test. You should document the ratio of FE1, FEC is reduced. Normally it is more than 0.75 or 0.80, 75% or to 80%, and it is more than 0.90 in children. Then confirm the variation in the lung function. The greater the variation in the lung function, the more sure you are that this is asthma. Then you have to give a bronchodilator and see the reversibility of bronchodilator. FEV1 reversibility of 12% and or an absolute value increase of 200 ml, then you say that it is a reversible FEV1. excessive diurnal variability from 1 to 2 week, twice daily PF monitoring can really help in this. So what I'm trying to say is that if you can't do pulmonary function tests that are often, but if you give a person and teach him how to do a peak expiratory flow rate, then he can do it at home, and if he is able to show that there is a diurnal or variability during a week time, it confirms the diagnosis of asthma. Or sometimes you have given a patient bronchodilators and the controller medicines, and you find there is a significant increase in FEV1 or peak expiratory flow rate after 4 weeks of controller treatment. It also confirms the diagnosis of asthma. If you see, this is a typical spirometric finding. You can see a normal, and as the obstruction increases, it comes down, and once you give a bronchodilator, then it will again go up. And if you show the reversibility, 12% an absolute value increase of 200 ml, you are sure that there is a significant reversibility. So just to summarize again what I said, first is the history and symptoms. Are the symptoms typical? If they are typical, then you do a history. After you do a physical examination of the patient, and if it is also suggestive of asthma, then you get a lung function, a spirometry or a peak expiratory flow rate, and do a reversibility test. If it shows reversibility, you are sure it is asthma. So almost more than 50% of the patient would show this pattern, and you are very sure of asthma. Now there may be a patient who doesn't have a classical symptoms, who doesn't have a finding on history and examination. You must think of an alternate diagnosis. You should not miss an alternate diagnosis. Many a time patient is labeled with a certain diagnosis and just remains like that. So if alternate diagnosis you confirm, you treat accordingly. Then suppose there is no alternate diagnosis, then what you can do is you can repeat the lung functions at another occasion or when patient is symptomatic. And if you find the findings, then of course you can start the treatment and in these patients. The other way is sometimes when you are not able to confirm because you can't do lung functions repeatedly in your office, then you can give them a trial of empiric treatment with ICS and LABA, review the response and do a diagnostic testing with 1 to 3 months, and if shows reversibility, then also you confirm the diagnosis of asthma. But always remember, you have to differentiate it from COPD, because this can be confused with the COPD, and there are patients who have an overlap of asthma and COPD. So history and physical examination, then you do a lung function, show reversibility, you confirm the diagnosis of asthma. If you don't show reversibility, think of alternate diagnosis or repeat the test at a later date and confirm the diagnosis of asthma. Before I go into the treatment, I would like to discuss some of the habits, particularly in a country like India. This was a study done where 53 questions were asked to the patients about general health, diagnosis, control of asthma. And what they found, that daytime symptoms were seen in 29% of the patients who require 1 to 2 times a month, 1 to 2 times a week, 29%, every day 42%. As you can see, a lot of patients are quite uncontrolled, and nighttime symptoms were also seen in a large number of patients. When they were asked, is their asthma controlled, 69% said that his asthma is controlled, but when they analyzed, they found 0% patient had a controlled asthma. Partially controlled 31%, and actually it was 60%. Uncontrolled, there was no data, but 40% of the patients were uncontrolled. And another habit which has been seen in a country like ours is a more reliance on a SABA, that is short-acting beta-2 agonist. They will not take controllers, but they will take a lot of the short-acting beta-2 agonist, which really does not help to relieve the symptom in the long term. And this is another, and it was seen all through all severity of asthma. It was seen in a severe persistent, moderate persistent, mild persistent and mild intermittent. Everywhere the short acting beta 2 agonists were being used too often. Patient commonly takes, this is another study which showed that patient commonly takes very high doses of inhaled beta 2 agonist in the 2-week period leading up to a hospital attendance with a severe exacerbation of asthma. And they also found the non-adherent to the inhaled corticosteroids. So patients rely more on, because it gives them immediate relief and they feel this is a better. And it is a duty of a doctor to educate his patient that what is right. Then the other thing is what happens with the repeated exacerbation or repeated acute attacks. It will not only worsen the inflammation, it has been seen that it leads to the excessive decline in the lung function in these asthmatic patients. And many a patient may have a irreversible lung functions. And this is another study which showed that treatment with inhaled corticosteroid early after diagnosis not only reduces the risk of severe exacerbation, but is associated with attenuation of decline in lung function associated with an exacerbation. So if a person doesn't take the inhaled corticosteroids, the drop in FEV1 would be faster than in patients where he takes inhaled corticosteroid, the drop will be slowed and it may not drop and the exacerbation would be much less. So what are the risk factors for exacerbation? If any one of these is present, that is a risk factor for exacerbation, like patient who's been ever intubated or in the ICU for asthma, patient who had more than one severe exacerbation in the last 12 months, patient who has a comorbidity like obesity, rhinosinusitis, or has a food allergy, or patient who uses excessive SABA. Some people will finish one canister of short-acting beta-2 agonist in a month. Low FEV1, especially if it is less than 60%. Patient who is smoker, patient who is exposed to allergens quite frequently and is sensitized. Also, they have seen that patient who's got an incorrect inhaler technique and poor adherence. Then elevated nitric oxide in adult with allergic asthma, obesity, pregnancy and high level of blood eosinophilia, they have also been included as a risk factor for exacerbation. Risk factor for fixed airflow limitations is when patient doesn't take inhaled corticosteroid, smoker, occupational exposure, mucus hypersecretions and blood eosinophilia. For medication side effect, of course, the steroids, high dose potent inhaled corticosteroid, they also lead to side effects. Before we treat a patient of asthma, I think it is important to assess the severity of disease. How can you do it? Asthma severity is assessed retrospectively from the level of treatment required to control symptom and exacerbation. When you should do it, you should assess the asthma severity after patient has been on controlled treatment for several months. Severity is not really static. It may change over months or years or as different treatment become available. Various institutions have divided the severity in different forms. One of them is by GINA is that mild asthma is when patient is well controlled with step 1 and 2. That means as needed SABA or low ICS. Moderate asthma is when patient is well controlled with step 3. That means a combination of low dose ICS and LABA. And severe asthma is when patient requires moderate to high doses of ICS, LABA plus add-on or remain uncontrolled despite treatment. Mild, moderate and severe. But other societies have differentiated severity into different form, like intermittent asthma, mild persistent asthma, moderate persistent asthma and severe persistent asthma. More or less it is the same. So what it really means is, our intermittent asthma is characterized by a patient who has daytime asthma symptoms occur 2 or fewer days a week. So like he has a symptom only 1 or 2 days in a week. He has 2 or fewer nocturnal awakening in a month. So he doesn't get up more than twice a month. And he does not require the short-acting beta-2 agonist more than 2 times a week. No interference with normal activities. FEV1 measurement, when you do it, it is normal. FV1 FVC ratio between exacerbation is also normal. A mild persistent asthma is when symptoms are more than twice weekly. He has approximately 3 to 4 nocturnal awakening. He uses SABA more than 2 days out of 1 week. Minor interference with the normal activity. His FEV measurement may still be normal. Or 2 or more exacerbation requiring oral glucocorticoids per year. So that person will fall in the category of mild persistent. A moderate persistent asthma would be patient who has a daily symptom of asthma, nocturnal awakening more than once per week, daily need of SABA for symptom relief, some limitation of normal activity, and this FEV1 falls between 60 to 80% of the predicted normal. A severe persistent asthma is a person who keeps on suffering throughout the day. Nocturnal awakenings are occurring every day. He needs SABA every day, extreme limitation of normal activity, and his FEV1 is less than 60% of predicted normal. These are the patients who are very prone to exacerbations. So asthma management has 4 components. One is that you need to routinely monitor the symptoms and lung functions occasionally. Patient education is very important. You need to control the triggering factor, and you should also take care of the comorbid conditions, and you have to give them a pharmacological therapy for the control of their symptoms. The goal is, when you treat a patient of asthma, is to reduce the impairment from symptoms, minimize the risk of adverse outcome associated with asthma, that is hospitalization, loss of function, drug side effects, and you should have a minimum adverse effects from the asthma medications. So these are the goal broadly when you manage a patient of asthma. A patient who is totally controlled will be that who does not have a daytime asthma symptoms more than twice a week, doesn't have any nighttime waking due to asthma, he does not require the relievers more than twice a week, and he does not have any activity limitation due to asthma. That is, you say that it is a well controlled asthma. Partially controlled, you say when 1 or 2 of these are present, and uncontrolled, if 3 or 4 of these present, you say it is an uncontrolled asthma. GINA has come out with the guidelines in the form of stepwise management of asthma for last many years, and they bring out updates every year based on the current literature. And I am going to discuss basically the guidelines, how to do a stepwise management of asthma. They are basically based that you assess, adjust treatment, and then review the response. And there are also additional components which they have suggested, that you should educate patient so that they have a self-guided management of asthma. Treat the modifiable risk factors and comorbidities. Advise about the non-pharmacological interventions and strategies. Consider stepping up if the symptoms are uncontrolled, exacerbations or risk. But always check diagnosis, inhaler technique and adherence before stepping up the treatment in any patients. The new thing which they have added in this guidelines in the step 3 and 4 is the SLIT, sublingual immunotherapy, in adult who have HDM sensitive patients with allergic rhinitis who have exacerbation despite the inhaled corticosteroid treatment, provided FEV1 is 70% of the predicted. Consider stepping down if symptoms are controlled for 3 months, plus patient has a low risk of exacerbation. Normally, the ceasing inhaled corticosteroid is not advised in a patient who has a perennial asthma.
Yes, sir.
So, in step 1, that is patient who has a very infrequent symptoms, the preferred option is a short-acting beta-2 agonist. Short-acting beta agonists are highly effective for relief of symptoms. However, there is insufficient evidence about the safety of treating asthma with SABA alone, because we consider it as an inflammatory airway disease. So it is logical that person should be on, who has a perennial asthma, should be on some amount of low dose inhaled steroids. The option is reserved for patient with infrequent symptoms, that means less than twice a month of short duration, and with no risk of exacerbation, you use short-acting beta-2 agonist. The other options, in every steps they have suggested other options based on current literature, which is not so strong, that consider adding regular low-dose inhaled steroids for patient at risk of exacerbation. So a patient, once you label an asthma, ideally he should be on a very low doses of inhaled corticosteroids, and particularly in a patient who has a risk of exacerbations. And then a patient is not controlled on step 1, you go to step 2. In this you add low dose inhaled corticosteroid without any doubt. If you add low dose inhaled corticosteroids, it not only relieves symptoms and reduces exacerbations, but also prevents the hospitalization and death due to this disease. There could be some patients who would not like to take inhaled steroids. For them, in these guidelines, they have suggested other options, like you can put them on a leukotriene antagonist or theophylline, but they are less effective than low dose of inhaled steroids. And you can use intermittent inhaled steroids in a particular group of patients, like who says I get symptoms only this 1 month in a year when there is a pollen season. So you can start inhaled steroids at the onset of symptoms and then continue throughout the pollen season and at least 4 weeks after the patient is asymptomatic. Then if patient is not controlled on low dose inhaled steroids, then you add the long-acting beta-2 agonist. And as I said earlier, whenever you step up the treatment, it is mandatory to check the inhaler technique. A patient who's been taking for many years, he may still not be taking inhaler properly. So check the inhaler techniques and ask him the dosages, because he may not be taking the proper dosages. Then if you are satisfied, then you add long-acting beta-2 agonist. That is a combination of low-dose inhaled steroids with long-acting beta-2 agonist, and as needed SABA or a short-acting beta-2 agonist. Or you can also use a single inhaler which has a low-dose inhaled steroids and long-acting beta-2 agonist as a maintenance as well as the reliever. Like you keep a single inhaler which you use regularly and also for aggravation of symptoms. When you add LABA to inhaled steroids, it has been seen it also reduces exacerbations, it improves symptoms and increases FE1 and allows you to use low dose of inhaled steroids. And there are studies to show that if you use a single inhaler, maintenance and reliever as a single inhaler, which gives a similar level of control, and they've seen the exacerbations are less as compared to when you use SOS SABA. So one has an option of using a single inhaler as a maintenance, like you take a combination of inhaled steroids and long-acting beta-2 agonist, and as a reliever, like when a patient has symptoms. Then the other option in this is that if you don't want to add a long-acting beta-2 agonist, then you have increase the inhaled steroid dose. That's one option. Or you can add leukotriene antagonist or theophylline. But of course, this combination is less effective than a combination of inhaled steroids and long-acting beta-2 agonist. In step 3 in the new guidelines, they have suggested particularly a subset of patients who have allergic rhinitis. You can add sublingual immunotherapy in this group of patients. Then a patient is not controlled on step 3. Then you go to step 4. And as I said, check inhaler technique and the adherence to the treatment. And the preferred options in this step 4 in the new guidelines, they have given to the combination of low dose inhaled steroids and the long acting beta-2 agonist as a maintenance and reliever, or you can increase the dose of inhaled steroids and LABA combination and as needed short-acting beta-2 agonist. The other options again is that you can add as an add-on therapy in these patients who are not better with a medium dose of inhaled steroid and LABA combination. Then you add tiotropium to these patients as an add-on therapy, particularly patient who has a history of exacerbations. You can again in step 4 think of adding slit sublingual immunotherapy to these patients, or you can grow from a medium to high dose of inhaled steroids and LABA combination. But they have seen that in going from medium to high dose of inhaled steroids, it only increases side effects, it does not give much advantage to the patients. Or of course, you can add leukotriene antagonist or low dose theophylline. But I think the first choice is, and this is that you increase the dose of inhaled steroids and LABA combination and SOS-SABA, or you can use a single inhaler as a maintenance and reliever therapy. And then there are other options. Now, if patient is not relieved even with step 4, then you go to a step 5. These are the patients who have the FE1 is low, less than 60%, they're very prone to exacerbations, and their symptom persists despite the step 4 optimization. Again, you check the inhaler technique. Then in this step, you definitely add on tiotropium in these patients with a history of exacerbation. And there are other options. You can add anti-IgE like omalizumab for patient who has a severe allergic asthma whose total Ig level is high. Or you can add anti-IL-5, mepolizumab or rozanolizumab for severe eosinophilic asthma. The other add-on treatment for option 5 include, the step 5 include sputum guided treatment. This is not available everywhere. They have seen that if you give a sputum guided treatment, it reduces exacerbation and the steroid dose. Or you can add a low dose of steroid 7.5 milligram per day prednisolone into these patients and may benefit some patients. And there are other non-pharmacological intervention also have come up in this step, like bronchial thermoplasty is emerging as an add-on non-pharmacological intervention in these patients. Then what is a low dose, medium dose and a high dose? Beclomethasone and budesonide and fluticasone. These are the 3 common combinations we use very often. For beclomethasone, dipropionate, it is 100 to 200 is a low dose, 200 to 400 is a medium dose, and more than 400 is a high dose. For beclomethasone, dipropionate, CFC, the low dose is 200 to 500, medium is 500 to 1000, and high is more than 1000. For budesonide, low dose is 200 to 400, medium is 400 to 800, and high dose is more than 800. Similarly, for fluticasone, low dose is 100 microgram and high dose is 200 microgram. So one needs to know what is low, medium and high when you prescribe the inhalation therapy to your patients. So when you are treating patient, it is also important how to go about in managing these patients. Like low FE1, I said, is a predictor of a exacerbation risk. So you should do lung function in these individuals at least 3 to 6 months when patient has come to you, and then if patient remains all right, you can do it every year at least once lung function in your patient. And you can consider peak expiratory flow monitoring for patient with severe asthma or patient who have impaired perception of airflow limitation. Some patient does not feel that he is sick. So peak expiratory flow rate would be a very good modality in using this patient. Utility of lung function in adjusting treatment is really very limited in between, and it is the symptoms and the examination, all these things help you to adjust the symptom. How often patient should come to you? Ideally, once you're treating, at least once a month patient should show you in the first 3 months, and then every 3 to 12 months. During pregnancy, it is mandatory to see the patient in 4 to 6 weeks. And after an exacerbation, every patient should be examined after 1 week. Then when you step up the treatment, you should maintain the treatment at least for 2 to 3 months. And when a patient gets a viral infection or you feel or some allergen exposure, then you can step up for 1 to 2 weeks and then you can come down to the usual treatment. And of course, day-to-day adjustment can be done if you're using a single maintenance and reliever therapy. Then when to do a step down? If patient has been stable, well-controlled asthma, then after 3 months, you go from step up to go to the lower and find out each patient's minimum effective dose that control both symptom and the exacerbation. Then you should consider, as I said, that when patient has a well-controlled, his lung functions are stable for more than 3 months, like your peak expiratory flow rate is not showing much variation, there is no respiratory infection, patient is not traveling, patient is not pregnant, then you step down. Because if patient has a respiratory infection, you should not step down. Similarly, patient who is traveling, because change of place exacerbate asthma, so don't change. Similarly, patient who is pregnant, you don't change the doses don't step down once patient is stable on a particular dose. Always you record the patient's level of symptom control and always control the risk factor. And make sure that patient has a written asthma plan. Because if your prescription does not you do not write down what is your asthma management plan, the next time you may not remember what you really thought on the next. And always book a follow-up visit in 1 to 3 months. And when you step down on ICS, you step down by 25 to 50% at 3 months. Like patient was on a high dose of inhaled steroids. Then you come to first a medium dose and then go down on a low dose. So 20 to 50% you decrease the dose at 3 monthly is safe in these patients. Stopping ICS is really not recommended in a patient who's got a perennial asthma. Because what I have seen in practice also, that if you continue even on a 1 puff inhaler, their chances of getting symptoms, their symptom control is much better than stopping in a patient who gets a perennial asthma. And particularly the person who has a history of exacerbation, you should continue them with a low dose of inhaled steroids. And it is important that you educate your patient well so that they can take action when they have a problem. And always prescribe the medication which decrease the risk of exacerbation. And ICS, the inhaled steroids, definitely reduce the risk of exacerbation. Patient who's got more than 1 exacerbation in a previous year, consider giving them a combination of low dose inhaled steroids and formoterol, maintenance and reliever. There are studies show probably this is better, but we need more studies to put it at a first option in most of the steps. Patient should not smoke. If patient is a smoker, you should compel him that my drugs are not going to be effective if you do not stop smoking. You advise and help him also in the smoking cessation. For patient who's got a food allergy, appropriate food avoidance. In adults, food allergy is very uncommon, but if person has a food allergy, it can sometimes be very severe. So ensure that the patient avoids that food and tell him what he has to do when something like this happens with him. And when a person is a smoker, you should ask tobacco and give him advice at every visit when he comes to you. And encourage your patient for normal physical activity, exercises, because they should not limit. If they limit, it will have a detrimental effect on the control of asthma. Person who's got an occupational asthma, ask about the work history, remove the sensitizers as soon as possible, and person should be seen by an expert, particularly if person has an occupational asthma. And there are medicine which needs to be avoided, like patient has a pain, he should avoid NSAIDs or beta blockers. And if he has to use a painkiller, paracetamol is a very good drug for them. They should avoid the dampness, because some people have symptoms because of mold, and this, you should give them a proper instruction for the control in their homes. Sublingual immunotherapy, I have already talked about that it is an adult therapy in adult HDM sensitive patients with allergic rhinitis who have exacerbation despite inhaled steroids treatment, provided FEV1 is 70% of the predicted. You know, when you are prescribing inhalation therapy for your patient, it is important to choose the device properly, because there are multiple devices. There are MDIs, beta dose inhalers, the dry powder inhalers, different form of inhalers, and so you should assess the skill of the patient and then choose a proper device, because patient should not collect so many devices. A new physician should not add on to a new device. So it is important to choose a proper device right in the beginning, which he can take, which goes with his skill and education. Then avoid multiple different type of inhalers. You know, when you choose a single type of inhaler, and you check when he's taking that whether every opportunity you should ask, how do you take inhaler? It doesn't take much time. So you ask him, how do you take, even if he is taking for many years. I have seen patient taking for 5 years, still they were not proper. So check the inhaler technique, particularly if patient has come to you for a first consultation and is already on inhalers. Then correct, demonstrate him, physically demonstrate how to use the inhaler properly, and then check it how he takes it, and make sure before he leaves your clinic that he takes the clinic properly, and tell him to get the inhaler next time, because I'll have to check it. And because you must confirm, not only that time, you must confirm when he comes to you for the next time. So choose a proper inhaler, check he's taking or not, correct it if he's incorrect, and confirm when he comes next time. So to summarize, nowadays asthma is managed better with a stepwise management. And you have to take not only the pharmacology, but non-pharmacological interventions and education, which is very, very important for the proper outcome in your patient. You have to spend time in educating them, not only educating them about disease, about the inhalation, the importance of inhalation, so that their symptoms are much better. The step 1, you consider SOS SABA in this patient who has a less symptom. If it's not controlled, you add in step 2 low dose inhaled steroids. If patient is not controlled, then you add low dose inhaled steroids along with the LABA. If patient is still not controlled, you go on to medium and a high dose inhaled corticosteroid and a LABA combination. If patient is still not controlled, you add on treatment like the titopium, anti-IG omalizumab, anti-IL-5, the mepolizumab and rizalizumab in a particular who got eosinophilic asthma. These are anti-IL-5. Then you can also add on in patients who are really not controlled low doses of the oral steroids, and also the other modalities which have been found to be effective, particularly in step 3 and step 4, is a sublingual immunotherapy in a group of patients who have allergic rhinitis. And bronchial thromboplasty is also being recommended as a technique for the management of asthma in a higher grade of severity. Thank you very much.